Go. We are recording. So please watch the eye rolls, watch the tone, watch your body language, because it is on camera now. So without further ado, my name is Micah Hunt. I'm the host with the most in the pumpkin suit for the virtual presentation Friday. This is a weekly presentation education seminar that I put together since COVID to keep us educated, informed, and aware of things that are going on in the industry of healthcare and senior living, and to keep us connected and networking outside of our normal area. And if we had trade shows, we would be doing this on a regular basis. And so I just kind of put this together, and it's been really fun. The attendance has been great. I think everybody's been really enjoying this a lot. At least I hope they are. So today we have an exclusive sponsor, Caption Call, and Lisa Modishard is going to share a little bit about Caption Call. So Lisa, I will be quiet and you take over. You're muted, by the way. Okay.
I'm unmuted. Hello, everyone. Micah, as always, I'm just so blessed and honored to be a part of your group. And obviously having Dr. Kinney as our speaker today is so exciting for me. And fortunately, our company Caption Call, being a sponsor makes it all the more better to be in attendance today. Just a little bit about myself. I'm Lisa Modishard. I am a hearing loss advocate. I work on the board for the local Hearing Loss Association of America chapter. But most importantly, I'm an account representative for Caption Call in the central areas of Virginia. We provide captioning and amplified phones and mobile applications to people with hearing loss so they can communicate effectively. And with Dr. Kinney's topic today, we wanted to just make sure that everyone was aware that this is a wonderful benefit that you can provide to anyone you know or the communities that you serve. If someone has hearing loss, they would qualify to be able to receive the phones or mobile applications at no cost. It's federally funded through a provision of the Americans with Disabilities Act. So raising awareness, sharing with everybody here today, and helping to promote good, effective communications for the deaf and hard of hearing community is what we are hoping to relay today. And again, thank you so much, Micah and Dr. Kinney, for allowing me to be a part of this. And thank you to Caption Call, my company, or our company, for being a sponsor.
Awesome. Thank you so much, Lisa. That was really informative, and it's great to know that those options are out there. And it's a good segue to our speaker today, Dr. Ann Kenny, who needs no further introduction. She's a great person that I've been able to know, and she has a great, wonderful book that I hope she talks about after a little snippet as well that I shared last month about that as well. So Dr. Ann Kenny, it is now your show to take over in regards to difficult conversations in times of virtual visits.
Thank you. Yeah, thank you, Micah, for hosting me today and for having these virtual Fridays. I've enjoyed so many of that I've been able to get on. And Lisa and Caption Call, thank you for sponsoring today. I think it's a perfect marriage. And difficult conversations frequently need to happen over the telephone. And they should happen in snippets. So having the text that people can save and refer back to seems like a perfect example of how to have these conversations and build on them. So I'm excited to have you guys sponsor today's call. I'm going to share my screen. So my final thank you is actually to all of you on the telephone. This time of COVID has been amazingly difficult, especially for people in healthcare. We are often stressed in our jobs, and I am so honored and amazed at how people have stepped up and done such a beautiful job help serving people, especially people living with dementia, with all the isolation, with these multiple difficult conversations in this time of increased illness, in what's already often a difficult journey. I'm excited to talk to you today, and I hope that I can speed it along, because what I don't enjoy about COVID is that I don't get to learn from the group I'm speaking with as much as usual. I enjoy the question and answer, and I love learning from you. So I hope that I don't dwell too much in my own words and my own thoughts, and I get to share yours. And I gotta, and my screen is sharing, but it's not advancing there. I just wanted to kind of level set us on where we are in this time of COVID. And I know you probably all know this, but for me, it helps to kind of begin that most people with COVID, this is a couple of slides from the CDC about how often deaths are in those who are 65 and above. And if you look at the proportion of people at 85, or the number of people 85, if you think of that in proportions, that number would be far higher. And the comorbid conditions, and many of us work with people who have so many comorbid conditions, especially with vascular and unspecified dementia, which is near the bottom of that graph. But again, a huge number of people, another comorbid condition that puts people at increased risk. Most people are dying in hospitals. So a lot of what we do is getting people to hospitals. Unfortunately, sometimes it may not be the right decision for people living with advanced dementia. But you can see also that a lot of people are dying in nursing homes, making it so that our jobs are difficult in that we have to have these conversations often. So the highest risk group in this time of COVID, again, are people 65 and over, those living in long-term care facilities, but also people with comorbid conditions, lung disease and asthma, heart disease, even hypertension, anything causing immunocompromised conditions like cancer treatment, and then comorbidities, including dementia. So when I'm thinking about planning for COVID, I often, kind of my buzzword is often goals of care. This is an aggressive virus. It's more aggressive with increasing age and medical condition. We are entering our second phase. Most likely the rates of COVID infection are on the rise presently, and getting scary once again. And there's the added emotional impact of isolation, both on people living with dementia, and then everyone who's a care partner, all of us who are care delivery workers. So I need to often have people take a few breaths and think, what does hospitalization, does it align with your goals of care? Would the focus be better on comfort? Would it be better served wherever someone's living, such as home or a nursing facility? And what do we need to do to make that happen? So we often need to know to help people understand that they're going to have to make decisions in this time of many, many unknowns. I like to go back and get people to think about the goals of care. If there are no stated goals, what would be what would someone decide if they could now state their goals? And I find that when I'm talking to people, knowing the stages of dementia can help them, guide them. And so, like I said, my buzzword is often goals of care. When the decisions become less difficult, when you kind of zoom up to 20,000 feet and think, what are the biggest goals? And this is a word bubble, and I'm sure many of you know what happens in a word cloud, is that the most common answers become the biggest words. And when you look at this word cloud, it's things like love and family, time with family, talk, quality of life, conversations, I don't want to be a burden. Those, share. Those are the things that pop out to me. They're not shared decision making is small. It's in there. Symptom control, small. It's in there. Goodbyes is in there. moderate, but it's not medical issues. It's really about connection. It's really about quality. It's really about having a voice. And so I try to remember that this is what drives most people. That's what this word cloud tells me. Let's keep the focus on where people want the focus to be. So I am often asking, what's most important to you? What do we need to know from you? And are your goals to, again, at 20,000 feet, to prolong life? Is that the goal? Is it to maintain function, or is it to be comfortable? And helping people in the face of a tough decision to kind of back up and go to that higher level, the rest of the decisions start to fall into place. I do like to remind people that when I'm asking these questions, whenever we're all asking these questions, we will do our best to honor their preferences, whatever they may be. They're their preferences. I like to remind people that in studies looking at people in end stage dementia, if you took 100 people or 100%, 10% would choose prolonging life no matter what, for religious reasons, because they can't imagine losing a loved one, whatever reason. But about 10 people out of 100 would choose prolongation of life. 60 would choose comfort. So that's well represented. And about 30% choose something in between. If I can maintain function, I would want to do more. If I could have a certain period of more time of a certain quality of life, I would want to do more. I like to remind people that every choice is represented, and it's our job just to honor those. Especially in times of COVID, if somebody is sick enough that they're going to need a ventilator, and sometimes you know that when you're dealing with them, those people with advanced age and with dementia are not likely to survive going on a treatment. And then in that case, it's probably not a good idea to put them through the trauma of going to an ICU and being put on a ventilator, because it's relatively futile. And I think it's okay. People are looking to us to listen to them, but they're also looking to us for a little bit of advice. They haven't had the exposure to the medical field like we have. And while we don't want to be too patronizing or too guiding, we do want to be able to give them some advice when the time is right. So when I'm talking to people, often some of these difficult conversations are around hospitalization in the time of COVID. And I'm going to, and this actually is not just about COVID itself, but about hospitalizations for other things in the time of COVID. And so I ask, is your goal to prolong life? Then hospitalization is probably right. That's where you're going to get IV fluids. That's where you're going to get the treatments that are going to potentially prolong life. Some of the treatments can only be offered at a hospital. If your goal is to maintain function, sometimes the hospital may be right, but not always. Can the same interventions be implemented in the place of where someone is living? And sometimes that's your best choice then, to stay home, where you're not going to get over treatment, but not get no treatment at all. And when we are sending people to the hospitals right now, they're starting to get overcrowded again. We have to realize that there's a higher rate of infection. So at times I've been called, somebody's having chest pain, and should we send them to the hospital? Because then they may actually be exposed to COVID. They don't have COVID. One of the places that I work right now is a 130-bed long-term care facility. We've had no cases of COVID. We've been incredibly careful about who comes in, who screening people, and so going to the hospital means that person would have to come back and be isolated for a period of time, increased isolation, even above the isolation of being in a long-term care facility from the federal standards or the state standards, depending on where you live, and that if we can take care of it at the long-term care facility, we're trying to, so that we can avoid some of those changes. And then if the goals are comfort, then hospitalizations are probably to be avoided in this time of COVID. it's time for me to segue kind of to the next phase of this talk, and that is, how do we have these conversations? And whenever I look at this slide of the butterfly going from a larvae to a full-fledged butterfly, I always think this is the way we often think of the life cycle. But we often forget that the butterfly dies. And believe it or not, most butterflies are dead in 2 to 6 weeks. So, pretty short. Some of them make it over a year because they're the ones that migrate. But most of them are gone in a very short period of time. And we, in 2020 and in the 2000s, in the late 1900s, we don't think of death as much as my grandmother was born in the late 1800s, and for her, death was part of life, and because of antibiotics and hospitals and ICUs, we've kind of forgotten that. But it is true that we all live and then we all die, and even those of us in healthcare are taught to kind of think about survival more than we are to think about the full life cycle. And for that reason, it's often difficult to have difficult conversations. Common approaches to difficult conversations about values and goals given by people in the healthcare facility. We know that high needs people often receive excess care because we are not always realistic with family members about what we can and cannot do. We have communication habits that we avoid because nobody wants to be the bearer of bad news. We do information dump. We think, okay, I'm going to just tell them everything that I can tell them, and then they'll make a choice. Or we equivocate. I often hear people saying, well, we don't know for sure what will happen. We can give it a chance. Maybe it might work. And that may be true, but statistically, the chances are slim in many cases, and we're not telling people that. In the end, what happens is patients or their family members who have to be their surrogate decision makers do not understand the situation and what can realistically be done. So my goal today is to talk to you about, yes, these are our habits because we're human, and these are tough things to talk about. But with our healthcare provider hat on, we kind of need to shift a bit to really guide families. This slide, don't really read it. It's just to remind me to tell you that for us, this is a study out of BMJ, a British medical journal, that when we're doing our assessment, you can see that it's got several steps. We're looking at context. We're looking at what the whole team would think. We're putting together a plan, and then we're going to implement it, which then takes us to developing. And so this is what happens in our heads before we even go to the care delivery, which is in the last column. So if this is what's happening to us for healthcare workers, how do we expect a family member to get through all this process over a phone call in a time of crisis? And so these are my suggestions, or these are my guideposts. When you're talking to someone, to establish what has already been, to figure out what's already been established. What do they know about the disease? What do they know about what is happening in the trajectory of the disease for their family member? Or what does the individual know about their disease and where they are realistically in that disease? And then find out what is important, and then how does COVID impact it? If it is somebody who, of course, we've heard of cases where people who are 95 with heart disease go in the hospital and they survive. That does happen. It doesn't happen often. What resources are available wherever you are, and what resources would you need? So you need to hear what the options are for how the care is delivered. If somebody's going to go to the hospital, what will happen to them there? They want to know that. The family and the people living with dementia want to know that. If they stayed where they are, what would happen? Is there something in between? If they do take not the hospitalization, for example, if they stay back at a long-term care facility or with home care, what are the signs and symptoms that that may change, that then they would go. They need to know what guideposts on the way will help you say, if you make this decision, here's one of those flexion points where you'll change to comfort or you'll change to more aggressive care. And what are the timelines for looking at some of those? A lot of times, especially in COVID, people start to look better for a few days and then they take this big decline. And people aren't prepared because they thought they were better. The other thing that healthcare providers often do, not always, but often, is, and what I hear from family is, I heard that he was doing well. I heard he was doing fine. I heard his vitals were great. It's because we like to deliver good news. We love to say what's going well because we think of that as giving hope, and it's true. But we also need to make the picture more complete. While he's still in trouble, today he's stable, but I don't know what tomorrow will bring. And that helps people understand that we're not out of the woods. Or I often say to people, I have no idea, but I'll have a better idea. We're at a fork in the road, I often say. We're at a fork in the road and I don't know if he's going to get better or worse, but I should know within about 3 days, something like that. And that way I'm saying today he's okay, but that doesn't mean I can guarantee that tomorrow he will be. So how do we deliver serious news? And this takes time. This takes and some practice. First, I highly recommend getting ready. I don't know how many times I've overheard a care professional saying, feeling kind of in a rush to get a decision made and not having all the information they need. If they took, because they're also a little bit panicked, if they took a couple deep breaths and almost planned what's going to happen on the phone or on a Zoom call, get ready. Say, like, anticipate what would the question be, and gather that information before you get on the phone. Also, emotionally get ready. A lot of times when we deliver bad news, we're going to be met with an emotional response, and you have to be ready for that. People are not attacking you per se, they're responding. It may become an attack, but they're responding. And to not take it personally, but to be ready for that emotional response and have some kind of strategies ready so that you can keep your coming from a place of compassion and not a place of defensiveness, which is again what we most of us do. When we are attacked, we want to defend ourselves. But I don't think this is the time to do that. So 1, get ready. 2, understand, try to get, when you're on the phone, try to understand what the family, the patient, or the resident knows. Where are they in the knowledge of where we're going with this? And then 3, when it's serious news, you need to inform with the headline. And that means you're going to say what is the most important thing. So if it's, I'm calling to tell you that your mother has what we think is pneumonia. I'm calling to tell you that we're dealing with a fever. I'm calling to tell you that your family member fell. Then pause. Often what we want to do is we want to immediately jump in with all the rest of the information, and more information is going to have to be given, but you need to let whoever's on the other end of the phone, the other end of the Zoom meeting, take some time to absorb what you just said. And so that's why you need to lead with the most important thing, because that's what they have to kind of emotionally get ready for. Then you're going to respond to that. If they're silent, you give them a bit of time and you'd say, I bet that was hard to hear. Or can you tell me a little bit about what you're thinking? This is demonstrating empathy. You want to actually get out of their head and into their heart, and it will help guide the rest of your conversation. If you take a minute to say, I know that must have been a difficult thing for me to hear. I often apologize as well, saying, this must be terrible to hear over the phone. This must be terrible to hear from someone. I mean, when I'm calling, they often don't even know me. And I'll say, that must be terrible to hear from somebody you don't even know, and you don't know if you trust me. So I'm very honest and forthright about, you're getting information that you're not ready for, and I'm probably not the person you wanted to hear it from either. And those things help. And then the next point on my slide is underneath my box. So just a second, I have to figure out where I am. Oh, and then say, what can I, and then be ready to ask, it's in a way asking permission. Are you ready to hear more? What can I do to help you get ready for what's coming? And be, it seems like it takes more time, but it actually in the long run will take less time. Because when you inform with the headline, demonstrate empathy and ask what's next, people will often guide me so much better. They'll say, I just want my family member to be comfortable. And that helps me then frame the rest of the information in, she is comfortable right now, or she's not comfortable right now. If that's what you like, we can do that. And here's the give and take of if we do that. And again, I wish I could see your faces, or I wish I could hear what you're thinking. If any of this is falling flat, I hope in the question and answer period you definitely tell me how I could do this better and help inform you guys better. But in that point, when you're about to hear the emotion, when you do hear the emotion about the serious news that you're giving, sometimes it helps to name it, to kind of bring him. Basically, when somebody goes into a very emotional state, it's the flight, fright, or freeze. They're not going to hear much of anything you say. They're not going to be in any place to be making informed decisions. So you kind of have to bring their emotions down a bit. And there's several ways to do that. One is to name it. Say, you seem shocked by what I said. You seem saddened by what I said. But just name it, and that brings the intensity down a bit. The other is to show them understanding. When they say something, you're not supposed to say, I know how you feel. You're supposed to say, this helps me understand your thinking. Like if somebody says to me, I want her to live, and I'll say that this helps me understand. I'm sure you do, but I mean, I'm often telling people that someone is really on the cusp of death. And I say, I'm sure you do. And I wish I could make that happen for you. But it does help me know that that is one of your wishes. Respecting, often people at these times are like, I've done so much and she's still failing, or it's good to say, I can see how much care you've given your mother. I can see how much work you've put into making sure that he's comfortable. Things like that help bring, again, that emotion down so that they can hear you. Supporting them, letting them know that whatever they've told you, you'll do your best to get them what they need. To say, this must be difficult for you right now. I want you to know I am listening to you. Something like that. And then exploring. When they say something, if you're not sure what direction it's going, you can say, could you tell me a little bit more about that? Could you tell me what you mean by that? And that, again, helps guide your conversation. But most people, when I'm talking to them, tell me that they need more information. Both patients and, well, I'm a doctor, so I get to say that. Patients and family members. And so for me, it's often around dementia. But we could talk about this around any other disease you want to talk about as well. So I usually talk about dementia as a functional change. There's all kinds of ways to strategize dementia, to classify dementia. But for me, partly because it's the way hospice defines dementia, and that is an important aspect to change, I use the functional assessment staging. So in the FAST score, there's normal to moderate stages of dementia, stages 1 through 5 that you can read right here. 1 being normal, that people are doing fine, no difficulty. 2, they're starting to forget objects. 3, there's some decrease in job function or difficulty in traveling to new locations, or like pulling off a dinner party, something like that. Stage 4, when they start having decreased ability to perform complex tasks, such as handling finances. And this is when people start to really be noticed by family and friends. And 5, when they start to require assistance in choosing proper clothing. my mom lived with dementia, and I knew that she was having some dementia symptoms. My siblings didn't quite see it until one day she got a flat tire in Nebraska, which has two seasons, in my opinion, winter and summer. And she was out like in summer clothes, and it was well into late fall. And she almost froze to death while she stood outside of her car waiting for AAA to come and change her tire. She still had the wherewithal to call AAA, but she did not choose the right clothing for that season, and was nearly hospitalized because of it. And then I'm not going to tell you about stage 6 right now, because I think that's where I get more involved as a palliative care doctor. But in stage 7, we know that stage 7 is when people start becoming eligible for hospice. So when they move into the late stages of dementia, or stage 7, and they have something else, weight loss, multiple hospitalizations, maybe a skin breakdown, or a couple of physicians think that they're really starting to decline, you're actually eligible for hospice at this point. And telling people that helps family members understand that this might be the time to shift the focus of care from something for longevity and shift it to something much more towards comfort. So when people lose their ability to speak, are limiting that to very few words, not really being able to have coherent conversations anymore. At 7C, when they've lost the ability to ambulate successfully on their own without personal assistance, often in the late stage 6, they're starting to stumble and have near falls. But by stage 7C, they're no longer able to independently ambulate. 7D, when they can no longer sit up in a chair independently, and they need cushions or side rails to sit up. When people start saying, my mother, I don't know how she did it, she just fell out of a chair. And then further, when they lose the ability to smile or hold their own head up. This stage we know is late. And this is when we need to start having conversations about limiting medical care. Of course, at this stage, I think we should be talking about do not resuscitate and do not, no CPR, but because I don't think they're futile and they're not beneficial to the individual any longer. But this is when we also, and studies show, mostly studies out of Harvard University, Susan Mitchell, who's an amazing palliative geriatrician and palliative care physician who's done a lot of work on late stage dementia, shows that at this stage, at fast 7 and beyond, people have more harm than good with hospitalizations for things like hydration, treatment for urinary tract infections, including the antibiotics. We can, of course, care for the symptoms of urinary tract infections, pain, any kind of suffering, but not the antibiotics. The antibiotics cause nausea, they decrease appetite, they cause muscle aches and pains. And so in controlled studies where people with late stage dementia and a urinary tract infection got antibiotics or did not get antibiotics, those who did not get antibiotics had a better quality of life, and their survival was exactly the same. And so treating things like peridium for bladder pain, yes, but not treating with an antibiotic, because that causes so much more trouble for the individual as a holistic individual. And the same with pneumonia. We know that what's happening are people are aspirating, they're swallowing their mouth secretions, maybe food. If you treat with antibiotics, you're going to get another pneumonia and another, and each one's going to take function, and each one takes that quality of life down a bit more. Again, I'm going to use my mother as an example. She had probably 3 bouts of pneumonia in her late stage dementia. My mom was on hospice for 2 years, and I was very happy to keep her out of the hospital. And her quality of life wasn't too bad at all. And by not sending her to the hospital, I didn't have her poked and prodded. She knew where she was. She was loved by the people who delivered some of her direct care, and me being there to deliver emotional care. She did so much better by not going to the hospital. It doesn't mean I didn't treat her. I definitely treated her with care and love and compassion, but I didn't treat her with antibiotics. And she recovered pretty darn quickly. Took a lot of ice cream sometimes, but she recovered really well. And so this is another thing that I often say to people, go to Midas so you get a muffler. If you go to a cardiologist, you're going to get cardiology medications. If you go to a palliative care doctor, you're going to hear about hospice. But the reason in dementia that hospice criteria are linked to speaking and walking is because they correlate with your ability to swallow. So poor chewing, difficulty getting food down, all of that goes about at the same time that you're losing, the same time that the brain is not getting messages to your mouth and to your feet and how to successfully speak and walk. It's also not getting messages to your throat on how to swallow. It also is not getting messages to your bladder to briskly get your urine out of you. And that is one way that, so I often hear from family members, she's clean, I clean her. It's not, she's got another urinary tract infection. A lot of that has to do with dementia itself. It's not about cleanliness. It's about the disease progressing, and that there's no longer a brisk flush, which is our body's number one way to keep bugs out of our urinary tract. And so with that, you're going to end up with more cases of pneumonia, more cases of urinary tract infections, no matter what we do. Again, you see that by treating them over and over again, we're not helping, because the antibiotics themselves start to have either superbugs or just the side effects of antibiotics. And before I got into, I've been a physician for over 30 years, and I did research on frailty when I worked at the university. I did research on frailty, but took care of people living with dementia. And the people with frailty who were cognitively intact used to tell me, like, don't give me that antibiotic. It wreaks havoc on me. And that's how I started saying, maybe I shouldn't be doing this for people who can't tell me that it's wreaking havoc. So not that I'm not all for antibiotics in the right place in the right time, but I think at end stage dementia, it's not the right place. And so this is, for me, a diagram that helps me understand palliative care or curative / palliative care. You can see that early in the disease, way over on the left of the screen, that may be when you're in early, dementia is this chronic long-term disease. It's many, many years. And early on, of course, we're going to be doing curative things, but we also should be doing palliative things, in my opinion. I say better living through chemistry every time I get a headache. I am not one to suffer with a headache. I'm going to treat my headache. So yes, we should be doing palliative care from the get-go. But as you can see, as kind of you go through the diagnosis, you're going to kind of start shifting whether you're going to go curative and maybe start thinking more comfort, more palliative. And so for me in dementia is this chronic disease. You live with it for many years and very well. You can live very well with dementia, but there is a flexion point where you start to die from dementia. And I think that flexion point is kind of at the FAST-7C. But you can see it coming at FAST scale 6, where late in that, in FAST 6, you're going to not be able to toilet as well. That's kind of when people start not toileting well, when they start having urinary and fecal incontinence. That's a time to start thinking, are there limitations we should be putting on chronic diseases that will help people not live? Most people tell me they don't mind living well with dementia. They just don't want to linger in the dying with dementia part. And so that's where we have to start thinking, should you start backing off on things like chronic medications to prolong life? Should you stop work? People used to tell me, but my mom, I know with dementia, you should eat well. That's one of the things. But when my mom was recovering from pneumonias, the only thing she wanted was ice cream. And so I quit saying she needs her fruits and vegetables. I might give her a fruity ice cream. She was all for that, something Cherry Garcia. But it wasn't that I said, oh, she needs 3 squares or she needs six small meals. Less focus on prolonging her life and more focus on what makes her happy today. So many people tell me my family member is napping all the time, and they need more stimulation. Yes, they do need stimulation early in the disease, but as the disease progresses, they need more rest. Their brain needs rest so that they can engage with you well. Same with exercise. Pushing exercise, I am all for it early in the disease, but as the disease progresses, some people are so pushing of the exercise that it's no longer fun. So doing fun things, I'm for, and if it gets your body moving and stretching, yay. But not when it becomes the focus outside of pleasure. Again, I think I've already told you what I think about going to the hospital late in the disease, and the same with things like IV hydration. Our bodies know how to shut down and die peacefully and beautifully, and if we're pushing too much fluids, too much food, we set ourselves up for problems, and we don't allow for the natural death. And so at this stage of 7, I think it's time to think about more comprehensive advanced care planning. This is when you really start thinking, when would I no longer want to go to the hospital? When would I want to limit my care? And for me, it's a time to start thinking about, when is hand feeding versus feeding for pleasure the right way forward? And Judith Schwartz from End of Life New York has put forward an advanced care plan that says, and it's not for everyone, but when I get to a certain point in my disease, whatever that is, where my quality of life is not where I want it anymore, when would I want people not to put food in my mouth so much? Feeding is a complicated decision. There's so much that goes into eating. We think of it as love. We think of it as showing affection. But in advanced dementia, sometimes affection should be a hand massage or a hug, and not so much putting food in someone's mouth. So that's close to the end of my talk, and I think I'm getting about where Micah would want me to stop. But this is just Alice in Wonderland saying to the Cheshire Cat, would you tell me which way I ought to go from here? And the cat says, that depends a good deal on where you want to go. And she says, I don't much care where. And he says, then it doesn't matter which way you go, says the cat. So long as I get somewhere, Alice added with an explanation. And he says, okay, you're sure to do that if you only walk long enough. And that's the point. In the healthcare system, we often, our goal is to extend life in the late 20th century, early 21st century. But I think we're starting to shift to say, where do I want to go? Unfortunately, people with dementia often lose that voice. And so we have to become their voice. We as family members, we as healthcare providers. And so it's important to me to make sure that we think, where is it that I want to go? And not just go on the conveyor belt that the healthcare system often can be. I have one more slide these are thoughts and questions I tell family members to think about when they're in a crisis situation. But honestly, when a family member's in a crisis situation, I'm not sure they're as capable to kind of go through these steps as sometimes we are as healthcare providers, to help them frame that crisis so that they get the fact that not all treatment is without burden. And sometimes we have to help them balance. Are you going to get the outcome you want? Is the burden of the disease or the burden of the treatment too much? Is the burden of the disease too much? And help frame people's questions about this. And with that, I thank you for your attention. I think you gave attention. I don't know, and I guess I don't. I shouldn't worry about it. But I would love to hear questions. And as Micah said, I did write a book. It's called Making Tough Decisions About End-of-Life Care and Dementia. I wrote it after my mother died. I looked for a book to help my siblings cope with her end-of-life issues, and I couldn't find one. I retired early because I got sick, spent a year on the couch, and I thought, how can I practice medicine? And I wrote this book. and now that I'm off the couch and back in the real world, it's what I decided I wanted to do. It's where my passion lies. So I'm happy to answer questions about dementia, about anything, about end of life, about palliative care. Thank you again for your attention.
Thank you, Dr. Kenny. I mean, that was awesome. I'm super excited. Again, this is clapping sign language. So just remember that. Okay. I'm not just like waving my hand. So if you don't mind, Dr. Kenny, if you could stop sharing your screen so we can see everybody. There we go. So for those of you, yes, you will get CEU credits at the end of this event. For those that are on the phone, please email me that you attended today. Otherwise, you will not get the email. And I need that email so that we know that you're here. So please, please, please make sure you email me that you listened in. Now we're going to open up to questions. So please, if anybody has any questions, I've been seeing a lot of, this has been great, Dr. Kenny. This information was incredible. But now we'd like to really have people answer questions or ask questions to Dr. Kenny in regards to this presentation. So if you're sharing your screen, raise your hand. If you're not sharing your screen, there's a reaction at the bottom that you can wave your hand. So Charles, go ahead, sir. And then Brandy, I'll come to you next. Charles Wozniak, go ahead. I asked to unmute you. Go ahead and unmute yourself. Or are you just waving? I was just waving. Brandy, are you waving too, or are you? Fine, whatever. Does anybody have any questions? Questions meaning like raise your hand or unmute yourself and start talking. But we want to be kind to everybody. Kathleen, did you have a question? Kathleen Nees-Hepner? You came unmuted. Okay. Really, nobody has any questions.
Oh, no. So this wasn't very... So
no, I am. Hey, it's Tracy, Micah. I got a question.
Okay, go ahead, Tracy.
And there was a great presentation. I really enjoyed it. Very informative, a lot of good information. My father died this year in January of Alzheimer's. And so going through that whole process with him was just like you described in your talk. But I also know that a lot of healthcare people are not trained in Alzheimer's. And that was most upsetting too, because like you said, those emotional reactions from people and they're so cold and no empathy and things like that. It's like, and I have many nurse friends and they say that's just not any kind of training that they go through. So I was wondering if that's something that, on the horizon that people that will be part of a curriculum or something for nurses, doctors to be trained in this, because they really don't know how to deal with those kind of patients. And they don't really listen to the family. We try to tell them, no, he's not going to do this. He's going to do this, or he's going to be upset, or, whatever that was. And they just kind of refuse to listen to you.
Tracy, thank you. That you are absolutely right. Which is part of the reason I wrote the book. I realized that I had a different approach than a lot of my colleagues. I didn't realize it until my mother was showing signs of, and I'm a geriatrician, and geriatricians are usually much better looking at holistically. Family medicine often better looking holistically. But again, go to Midas, you get a muffler. You go to a lung guy, you get lung stuff. You go to a heart guy, you get heart. We are not taught enough empathy. No. On the slides that I showed, a lot of it comes from Vital Talks, vitaltalk.org, about how to communicate better. It's almost completely driven out of the cancer field. So again, much like 1950s, people didn't talk about cancer and we didn't tell people they had cancer. It was cancer survivors who started to change that conversation. And now we're much better. And it's changing the medical field to be more empathic in their approach. But it's still almost all in cancer. So what we're seeing now is this shift, this beautiful shift, where people living with dementia are starting to be starting to be their own advocates. And they are driving the conversation with dementia-friendly societies. And they're starting to drive conversations about nothing about me without me, and there'll be a movement. And I unfortunately, I don't think it'll be in my lifetime. I wish it were, but the movement is coming, and it's going to be driven by people living with dementia. And it will be to the point that physicians will listen, but we are not your group, you know. And that's why I'm so happy that you guys are on here and listening, because we, not me physicians, but we healthcare providers outside of the physician world need to help those people living with dementia have that voice, find that voice. It's a lot of what my book is about the surrogate caregivers. And I'm trying to write another book right now for people living with dementia on how to ask for some of these end decisions earlier on. But the bigger picture is treating me well, not me, but, you know, well, maybe me, who knows? But, you know, treating the person living with dementia well during the whole process. And you are right. It's going to have to come from the people living with dementia to really shake the old school of medicine and nursing. There is more, but it's the curriculum is packed with all kinds of, you know, new genetic things and new microbiology things. And so unfortunately, this doesn't get the press that it needs. But much like the AIDS crisis, much like every other movement, LGBTQ, the groups that are being underserved, and definitely, you know, dementia is stigmatized, death is stigmatized. It's going to have to be movements from those two fronts to make it change in medicine. But I'm sorry about the loss of your father, but you are absolutely right. And anything you can do to help move that ball forward, I'd appreciate it. And I'll help you as well. Let me know how I can be helpful to you and any group that you need.
Okay, thank you. Yeah, Mike has been a huge help, because when I met him and joined the Alzheimer's Association and did the walk this year, raised a lot of money and awareness and fundraising, it was just eye-opening to me. So yeah, I'm definitely going to keep that up.
Good, thank you.
And real quick, I have two people that I think want to ask a question. But just a reminder that at the end of this call, you'll receive an email with Dr. Ann Kenny's email information in there. So you guys and ladies that want to follow up with her, with being more informed or be a better advocate and be a better voice, you can follow up with her after this call as well. So you will receive that. Stephanie Page, I believe you raised your hand wherever you went. I don't know where you went. Stephanie Page? There you are.
And I don't have the best internet connection, so if I'm breaking up too much, let me know and I'll stop. But thank you so much. This was an awesome presentation, and I work with a hospice and palliative care team in a hospital setting, and we utilize a lot of those techniques you talked about. And just one of the challenges, I just wanted to share, like one of the challenges we're having, especially during COVID and having these conversations on the telephone, is you can't read body language. And so that pause that's happening, is it because they're crying? Is it because, you know, they're out in a wherever and something outside in their environment happened, or another family member is talking, and know how to give those pauses their ample time and how to respond to them. But I think one of the things that's really helped us is, like you talked about in the beginning, just naming everything. Like, even from, we have masks on, and so we might be kind of muffled. If you can't hear us, ask, you know, giving the families all that permission to be able to stop us and just really to trying to name everything that's happening and what's going on, because families might not feel as comfortable, especially on the phone when they can't see us, to be able to jump in or to interrupt or ask for what they need, because you're in a situation where you already feel so powerless because there's all these people with all this information, and, you know, they're looking at me expecting me to do something as the family member, you know, and so it can be a very overwhelming situation emotionally and otherwise for them. So that's just been really helpful for us, but it's just so hard in not being able to see that facial reaction and build that rapport that way.
Right. And Stephanie, I agree with you 1,000%. In those pauses, one, it's important to remember to keep them because they are uncomfortable, but you have to kind of hang in there a little bit. And then at the point where you want to say something, you can just say, like you said, name it. I'm sure, you know, are you doing, are you needing another minute? You know, just ask, just keep asking what they need. And it's a way to get through the process. Yeah.
Thank you for that question, Stephanie. Pete Turner. You're muted. Okay.
Hi, Ann. I just wanted to say thank you. I really enjoyed your presentation. I thought it was beautiful.
Thank
And
you.
I wanted to thank you too for sharing with all of us your personal story about your mom. I think it's just a wonderful example of kind of what folks, at least willing to talk about it from a personal perspective, or also from the professional, taking kind of the brave move of just reaching out and being out of pure compassion, and being able to use stories like yours to share kind of the benefits of some things that they've seen, or that, someone close to them has experienced. I think that story is so powerful, to really be able to personalize it I think that actually may hopefully kind of advance that movement
Right.
just a few inches closer than, truly folks who are experiencing dementia and those advocates. I think the family advocates and the us who work in healthcare, who see those benefits, because they're so, it's sad to say, it's so rare to hear that type of a story, that 2 years on hospice, or there's a number of other, my mom went through it with cancer, had months on hospice. It was amazing. And things that we accomplished are beautiful. So I thank you for sharing that. And thank you for that presentation. It was fantastic, phenomenal. If I'll say this, if there is any further education that anybody's interested in, I do provide some of those in services as well. So, I'm not, I'm by no means Ann.
Thank you, Pete. And I'm sorry about your mother, but yeah, actually the book, and Making Tough Decisions About End of Life, is also full of stories of people I've met over the last 30 years. And it was those stories of people that I had been engaged with that helped me realize that the journey with my mom could be so wonderful and so beautiful. And so it was important for me to share them in the book. Both, some of them are negative, where people couldn't handle something, but a lot of times it was just other people handling the journey of dementia and making choices that opened me up, that the choices other than just what's being offered by the somewhat discompassionate medical field often offers. And so that's what I was hoping to offer to other people that were going through things that don't have the advantage of sitting where I sit, both as the professional. And I saw it in the eyes of my siblings, and I thought, okay, they need more of these stories. And so that's what I finally wrote in the book. But thank you, Pete. And again, I'm so sorry about your mom.
You will, I'm going to work with Dr. Kenny to see about getting her presentation, her PowerPoint. I've tried sending it out with previous presenters, and it doesn't work well in the bulk email that I send. So if you would like her PowerPoint, you can either do one of two things. You can email me directly and ask for it, or wait for my email with Dr. Kenny's information and then ask her for it directly. And that way she can stay in touch with you all as well, if that's okay, Dr. Kenny.
Yeah, that'd be great. Thank you.
Okay, because I'm sure she would love to have more advocates on her
Absolutely.
side. So it'd be better if you talk to her than me, because all I'm going to do is to say, Dr. Kenny, help. So again, does anybody have any more questions? We're going to start closing up because it's a little after 12, and I'm sure everybody's getting hungry, including our wonderful speaker. So without further ado, I'm going to stop recording now. So.